Hello, welcome to this NMC OSCE tutoring video. My name is Hannah. I am a registered nurse, a university lecturer, and have been an NMC OSCE programme lead. And if you're new to my channel, I share lots of advice and up-to-date, accurate information based on my nursing knowledge and experience as a lecturer and an NMC programme lead to help you pass your NMC OSCE exam and study. So today I'm going to be doing a video for the children's nurses. So I've had lots of requests for this. And finally we got round to do it and to give it to you as a little Christmas present. So I'm going to be doing the APIE tutorial looking at the asthma scenario for the Child OSCE students. Okay, so if you're a child NMC OSCE candidate, you have two potential APIE conditions for the child. So one is the post-tonsillectomy bleed, which I've already done a video on, and the other one is the asthma. So today I'm going to go through the asthma. So just quickly, I always try and teach and embed the underpinning knowledge about your conditions, about what you're doing and why, because it will massively help you in your NMC exam. And remember, you need to demonstrate more than just marking criteria. You should be demonstrating your knowledge. Child nurses, you should be demonstrating your specific child nursing knowledge so the examiner can make a holistic judgment on you as a safe and competent nurse. So asthma is one of the most common long-term medical conditions in children in the UK. It's about 1 in 11 children and young people live with asthma. So quite a common condition that you might encounter. And we do in the UK actually have one of the highest prevalences to emergency admissions and death rates from childhood asthma in Europe. NMC OSCE prep, you should be using the evidence base, okay? So you should be engaging in the evidence-based resources and using that to support your knowledge. So the information I'm going to talk about today comes from two sources. So the British Thoracic Society guidelines and the NICE guidelines on asthma management. So those are two key resources for you to go away and look at as well. So like I said, asthma is common. It's an inflammatory condition and it's characterised by what we call airway hyper-responsiveness. Okay, so the airways become hyper-responsive to certain stimuli, and that causes them to, airway, if you get like obstruction, so airflow obstruction, you get increased mucus production and you get this inflammation. And obviously those most frequent symptoms are things such as your cough, your wheeze, chest tightness and breathlessness. Asthma symptoms can vary over time and in intensity, and they can come on gradually, or you can get a very sudden acute asthma attack as well. So risk factors, so already having an allergy related condition, so children that have eczema normally at quite high risk of having asthma or certain food allergies or hay fever. There might be a family history of asthma as well. Having bronchiolitis, so that's a really common childhood lung infection, which you'll be familiar with as child nurses. If the parents smoke, okay, and these are quite important things to pick up on in your assessment briefing, because these may be health promotion things that you need to pick up on and talk about in your holistic assessment. If the mother smoked during pregnancy, and babies that are born prematurely or with a low birth rate. So triggers, so a lot of asthmas are triggered by infections, so maybe colds and flu, and again, a good thing to read and pick up on your assessment briefing. Potential allergies, smoke and pollution, so we know with increasing air pollution or children that live near very busy roads with high air pollution, there are more cases of asthma. Some medicines, so some things like anti-inflammatory painkillers like ibuprofen and aspirin can, not always, trigger asthma attacks. Emotions, so stress or laughter, and weather. So when the weather gets very cold, we might see more admissions to asthma as well. Mold and damp, so things such as social housing and poorly heated houses. So again, that's another thing maybe to pick up on in your assessment briefing potentially, and it can also be induced by exercise. So like I said, the main signs and symptoms are obviously difficulty in breathing, wheeze, coughing, reduced oxygen saturation. It's also very, very scary for the person who's having an asthma attack. If you ever looked at after anyone with acute asthma, it's also very, very scary for you as a nurse, because they can be very, very unwell and can deteriorate and go into a cardiac arrest situation quite quickly as well. Different levels of severity with asthma. Okay, and this is from the NICE guidelines. And again, it's just good to build your knowledge on this. You can be looking after children in the UK with asthma. So what we call is a moderate acute asthma attack. So the child's able to talk in sentences. Their oxygen saturations are greater or equal to 92%. Their peak flow is greater or equal to 50% of their best or predicted. And then some heart rate changes there. And the respiratory rate is equal or less to 40 breaths per minute in children aged 1 to 5 years and 30 in children aged 5 years. So those are quite good things to be aware of when you're doing your OSCE assessment station. You'll get your observations. So, if your child is hitting these triggers, then you can, be confident that you're identifying them as moderate asthma. Then you've also got severe, so when the severity is severe. So this is when they can't complete sentences in one breath, or they're too breathless to talk or feed. That oxygen saturations are less than 92%, and their peak flow is sitting around 33 to 50% of best or predicted. Again, there's heart rate parameters as well, and also your respiratory rate parameters. So the respiratory rate is greater than 40 in children aged 1 to 5, or greater than 30 in children over 5 years. So good things to know and be aware about in terms of your assessment station. And then we've got kind of life-threatening acute asthma. So this is when the child is cyanosed, what we call got a silent chest. So there's very minimal air entry moving in and out, or none at all. Really poor respiratory effort. They can have quite a low blood pressure. They can be exhausted. Their oxygen saturations are less than 92%, and their peak flow is less than 33% of their best or predicted, and they can also be confused. So what's our treatment for asthma? So treatment should be high flow oxygen, should be given to all children with the aim to keep their oxygen saturations greater or equal to 94%. Okay, so we're looking for that 94 to 98%. We also treat with salbutamol. So salbutamol is a short-acting beta-2 agonist, so it helps dilate the airways. And also in acute asthma, children may be prescribed prednisolone. We might also be doing peak flow measurements on those children as well, or should be, to see where they are in relation to those targets. So this is important to know, because these are medications that you may find your implementation chart. I'm going to go through that. But also when you're thinking about your plan for this child and verbalising that to your examiner as well, these are key things to be thinking about. So what are your assessment priorities? So obviously you're going to need to be managing the airway and the breathing, okay? You'll need to do your full A2 assessment anyway, but obviously really thinking about that full breathing assessment, maybe considering the position of that child, verbalising around oxygen administration. You might want to think about their inhalers. Okay, are they taking their inhalers with a spacer? That's something you can have a discussion around in your holistic assessment with the parent as well. Some health advice, health promotion on inhaler technique as well. And also there will be like anxiety and distress. Okay, your child and parent might be very anxious, and you'll need to manage that as well. So it is really important, obviously, in both your APIE stations to complete your PEWS charts correctly. And I have got a separate video on the PEWS chart. But in relation to your asthma, you'll need to ask these questions around respiratory distress, because they may very well be scoring mild for accessory muscle use or moderate. So when you ask about respiratory noises, if there's any inspiratory or expiratory noises like a wheeze, okay, that automatically is going to put them on the moderate scoring for that respiratory distress. And so it's important that you ask your examiner for these respiratory distress signs in order to assess that correctly. Your mannequin for the child or baby might be on oxygen, okay, in this station as well. So you'll need to ask the examiner how many litres of oxygen the child is on, and make sure you document that correctly, okay. So on the right hand side here is your flow litres. Okay, so if the examiner says they're on, 8 litres of oxygen, here we just plot it over here to here, which is 60%, and that would score a 4. So 2 really important parts of your PEWS chart to do. In terms of your holistic assessment, so again, your focus here is going to be on the asthma. You want to find out, obviously, how many asthma attacks they're having. Like I said, are they using their inhalers? What's their inhaler technique like? Are they using a spacer? Are there any triggers? And then we want to look at some of those psychosocial issues as well. So just considering, who's living at home with that child, look out and be aware of any safeguarding risks, okay? Again, because we know some contributing factors to asthma are smokers, okay, and some housing issues such as mold and damp, picking up on any of those issues and talking to them with the parent, just approaching the parent in a professional way about reducing smoking and offering, information to support them to make that decision. Again, you want to find out what your child's interests are they attending school, anything that can help reduce their anxiety, so anything that you can use for distraction techniques as well. Again, always check your children are up to date with immunisations as well. It's a good opportunity to add some health promotion advice in there. Okay, so planning. So obviously with asthma, a really obvious care plan and an expected care plan would be difficulty in breathing. Okay, so for example, I've put Robin is experiencing difficulty in breathing due to asthma attack, as evidenced by a respiratory rate of, I take my respiratory rate from my assessment station, and a PEWS respiratory distress score of that sectional respiratory distress. So I could do that. Obviously, my aim would be for Robin to have reduced work of breathing, and then I could have my target normal range of respiratory rate, and the target saturations have been greater than 94%. So my re-evaluation, so on here I've put today in every 30 minutes. Obviously take your PEWS monitoring frequency. If your PEWS monitoring frequency is every 15 minutes, then you'd want to be re-evaluating this every 15 minutes. If your PEWS monitoring frequency was every 60 minutes, I'd be using that to support my re-evaluation timeframe. So planning, so quite straightforward for shortness of breath or respiratory distress. We're obviously going to explain plan of care to the child and the care or parent and gain consent. We're obviously going to do the PEWS monitoring as prescribed and escalate this as policy. We should have a separate point here, which is really focusing on assessing work of breathing, respiratory rate, rhythm depth, oxygen saturation, signs of respiratory distress and any respiratory noises. Here we're going to be administering oxygen and maybe salbutamol inhalers and monitoring those the effectiveness of that. If the child is able to tolerate and can complete a peak flow, then that is an important thing to do. And we'd want to document and escalate those results if they were less than 80% of what is predicted. We can support the child into an upright position to improve lung expansion. We could also provide distraction techniques to reduce anxiety and try and encourage some more controlled deep breathing. Obviously depends on the severity of the asthma attack. We're obviously always going to escalate if the child's condition deteriorates, and we're going to ensure the parents know how to call for help if anything becomes more difficult for that child with their breathing, and we're going to document all the care. So medications, so like I said, the core treatment for asthma is steroids. You might have some steroids on your medication chart to give or that have been given. Again, you can go to the BNFC, which is, and look up these medications to familiarise yourself with these more before your exam. Prednisolone dosage is done on weight, so 1 to 2 milligrams per kilogram, with a maximum dose of 40 milligrams. So that's from a 1 month to 11-year-old, and then the older children, they can have 40 to 50 milligrams once a day, and it's normally for short periods of time, so 3 or 5 days. You might be given some analgesic. Maybe the child's got some chest pain with their asthma, or is distressed, or generally feeling unwell if they've maybe got an existing infection. So again, just be really clear on your paracetamol dosages for your different children's ages. I've put them on the right hand side here from the BNF. Again, if you're unsure in your exam, just double check that. So other medications you might see on your chart could be obviously antibiotics if they think there is an underlying infection. So just check for those and check for allergies. There might most probably be some as required inhalers, so salbutamol or nebulizers. Obviously in your implementation station, you're not going to be giving inhalers or nebulizers, but do make sure you just check in with the parent and ask whether the child, if they feel the child needs them. Most of the time, well, all the time they say no, because you're not going to be assessed on that in this station, but it is going to just show that you're really thinking about what's on your chart. And also a lot of the children in the OSCE exams have some form of multivitamins written up as well. They might have some enoxaparin, so the subcut injection we give to reduce blood clots whilst people are in hospital and not moving. So those are common things you might see on your medication charts as well. Maybe some anti-sickness and potentially say or Dansitron in children. So evaluation, so obviously it depends on who you're evaluating to. If so evaluation, it obviously depends who you are handing over to. If you're just doing a nurse-to-nurse handover, then you want to think about all those ongoing things that you want the nurse to continue to ensure the patient is safe, okay, and to ensure continuity of care. So obviously you're going to want that nurse to continue to do their PEWS monitoring as per the PEWS policy and prescribed frequency. You'd want them to continue to assess for signs of respiratory distress. You'd want them to continue to support and provide emotional support to the parent and the child. If you have identified any social issues, again, it would depend on your scenario, things with housing, parent smoker, possibly safeguarding, then you'd need to make sure the nurse taking over from you follows those up. Going to continue administration of prescribed oxygen inhalers if the child is still receiving those when you get to your evaluation station. Continue peak flow monitoring and encourage them to do the parent and child to keep a diary at home. If the child's on oxygen, you can also think about handing over and ensuring that the regular mouth care and water and skin checks are done. Encouraging fluid and food intake. If from your evaluation scenario it looks like the child has deteriorated and you're handing over to the doctor, so you just want to be really clear in your recommendations. I'm really concerned about this child. Maybe you've got a new escalated PEWS score, a very increased respiratory rate or some respiratory distress, and you just want that doctor to come and review them immediately. That is your recommendation. So just two possibilities there. So I hope that was helpful for the charge students. I know you've been asking for that for a long time. I would view this in relation to with the PEWS video as well, if you haven't done that as well. And like I do child OSCE tutoring as well. If you want some additional help and support with your NMC OSCE exam, we've also got a child OSCE study book for APIE and clinical skills if you need access to scenarios and some additional support. You can email me on hannah.lames@outlook.com or visit my social sites, so Facebook, Nurse Tutor, Tutoring with Hannah.